So now we're going to zoom right in and have a look at what happens during gas exchange. So we're going to zoom into the alveoli, which are the smallest units of the lung. So what is an alveolus? It's a gas exchanging unit of the lung designed to facilitate oxygen and carbon dioxide diffusion. How is it adapted to do this? Well, there's four main things. So if we look at what governs the rate of diffusion, we can see that there's an area of space here that oxygen and carbon dioxide are diffusing through. So diffusion is the net movement of particles down their concentration gradient despite the movement being random. So we have a concentration gradient of oxygen here, where the concentration is higher in the alveoli than in the blood. So the oxygen is going to diffuse from the higher concentration through this partially permeable membrane, which is the alveoli and the endothelium, into the blood. That's the net movement, but remember that the movement is actually back and forth, it's random, and it's only the collective movement that's down the concentration gradient. So the rate that this equilibrates, the net flux happens, is governed by Fick's law. So this is one iteration of Fick's law. You have the concentration gradient, so concentration 1 minus concentration 2, times the area over the thickness times d, which is the diffusion coefficient, which is different for each molecule. So how is the alveolus adapted? So number one, in terms of concentration gradient, a very steep concentration gradient of oxygen and carbon dioxide is set between the alveoli and the blood by the alveolar ventilation and the pulmonary blood flow. So new air is constantly coming in and the pulmonary blood is constantly taking the air away, the oxygen away that has been diffused in already and equilibrated, so that maintains the steep concentration gradient. Number two is in terms of area. The alveoli have a very large surface area. There's a lot of them, and they're very small and they have a very large surface area to volume ratio. Number three, thickness. So the alveoli are only one cell thick, and the endothelium of the pulmonary circulation, so the capillaries, are only one cell thick as well. So that creates a very small thickness. And number four, diffusion coefficient, we'll get onto for the individual gases. So there's a way that we can rewrite Fick's equation in a different way to have a closer look at the diffusion coefficient. And we can do that using Henry's law. So Henry's law states that concentration equals partial pressure times solubility. So we're looking at the concentrations here, and we can replace these concentrations with partial pressure times solubility. Rewriting the equation, for a specific gas in a specific medium, for example oxygen in the blood, the net flux equals delta P, which is the partial pressure gradient now, times the area over the thickness times d, small d, where d is proportional to solubility over square root of molecular weight. So things that influence diffusion now, we've got two more things, the solubility and size of the molecule. Now, solubility is pretty intuitive. If something dissolves more easily, then more soluble molecules will diffuse faster. Size, so the smaller the molecule is, the faster it diffuses because it can get through the gaps more easily on a molecular level, so it diffuses faster. But solubility has a greater contribution than size. Now, carbon dioxide versus oxygen, let's look at these properties of the two molecules that we're looking at. So carbon dioxide is obviously larger, it has a carbon and two oxygen molecules, whereas O2 is just two oxygen molecules bound together. So if we're looking at size only, then carbon dioxide diffuses at 85% of the rate of oxygen if we're considering size only. However, carbon dioxide is much more soluble than oxygen, and the solubility coefficient of carbon dioxide is about 0.7 milliliters of carbon dioxide per litre per millimeters of mercury, which is about 23 times larger than the solubility coefficient of oxygen, which is 0.03 milliliters of oxygen per litre per millimeter of mercury. So for a given partial pressure gradient, carbon dioxide diffuses 23 times 0.85 equals 20 times faster than oxygen. And we can see that here, that carbon dioxide diffuses faster than oxygen. So this graph is showing the time course of oxygen diffusing into the blood and carbon dioxide diffusing into the alveoli and the equilibration there. So remember that while diffusion is the net movement of particles down their concentration gradient, there's still movement backwards and forwards. So it's not just like all the molecules move in one direction all at once. That would be very useful, but no, all the molecules are moving randomly backwards and forwards, and they need time to equilibrate. So they have a very short time to equilibrate because the pulmonary circulation is moving blood along very fast. So the transit time from the beginning to the end of the pulmonary capillary, in which it's exposed to the alveoli air and it has time to exchange gas with it, is less than 1 second. So this equilibration needs to happen very fast between both gases. And the amazing thing about the pulmonary system is that it does equilibrate very fast. There's actually room to spare. So if we look at this graph where we're plotting the time in the capillary of the pulmonary blood and the partial pressure of oxygen in the blood and the partial pressure of carbon dioxide in the blood in red and blue respectively, then we'll see that, so this is the blood after it's been used when it needs to exchange gas, so the oxygen levels are low and carbon dioxide levels are pretty high. At time 0, the blood is exposed to the alveolus and the alveoli air, and then oxygen goes up very rapidly and carbon dioxide goes down. It exchanges even more rapidly because it's more soluble, and you can see that there's a slight difference in the time that it takes for each to equilibrate, but it happens very fast overall. And there's actually a diffusion reserve, which is the time that's left after it equilibrates. So it still has this time left, but it's already finished its job and it can move on. So that's what the diffusion reserves are. So the gas pressures are equilibrated, and this is finished at the venous end of the capillary. So going from arterial to venous end, it's finished somewhere around here. It's very fast, and the alveolar ventilation needs to be matched to the alveolar blood perfusion perfectly, so that it allows enough time to do this. And the amazing thing about our pulmonary systems is that it does. How oxygen is carried in the blood now, and almost all oxygen in the blood is carried bound to a molecule, a protein called haemoglobin, which exists within red blood cells. And this is the primary function of a red blood cell. It's got adaptations such as having a dimple and no nucleus to allow it to hold as much haemoglobin as possible, because it wants to transport as much oxygen as possible. And the rest of the blood is dissolved inside the blood plasma, but most of it is in the haemoglobin. The structure of haemoglobin, it's a globular protein. There's 4 polypeptide chains per haemoglobin molecule in adults. Each chain contains a hydrophobic pocket, which contains a ferrous porphyrin group called a heme group, and the heme contains a Fe2+, an ion 2+, a ferrous ion, and this ferrous ion is what associates with 1 molecule of oxygen per ion. It associates reversibly and allows the oxygen to be carried. So the 4 polypeptide chains in the haemoglobin molecule are named alphas, so 2 alpha chains and 2 beta chains with slightly different structures. And each of them carry a heme group, each of which contains an Fe2+ ion. So each Fe2+ ion associates with 1 molecule of oxygen, and in total this molecule of heme can carry 4 molecules of oxygen, or 8 atoms of oxygen. So there's 3 main types of hemoglobin. Type A is the normal adult hemoglobin with this structure. Type F is the fetal hemoglobin, which is slightly different and has a higher affinity for oxygen. It has a slightly different structure as well, and is gradually replaced with type A hemoglobin after birth. Type S hemoglobin is not normal, it's sickle cell hemoglobin, and it's a genetic disease caused by a amino acid substitution. It's a valine substitution for glutamine, and the beta chain has decreased hemoglobin oxygen affinity, and that decreases the solubility of deoxyhemoglobin. It's not bound to oxygen. The hemoglobin molecule is less soluble, and that causes the molecules to crystallize, and it causes the red blood cells which contain this crystallized hemoglobin to stretch out into a sickle or moon-like shape, and it causes the red blood cells to be very fragile, so people get anemic. And this is just an equation showing the reversible binding of 4 oxygen molecules per hemoglobin molecule, 1 to each heme group, creating oxyhemoglobin. So deoxyhemoglobin binds to oxygen to create oxyhemoglobin. And oxygen binding is cooperative. So what that means is when the first oxygen molecule binds, it alters the structure of this hemoglobin molecule so that it makes it easier for the second oxygen to bind. And the second oxygen and the first oxygen also alter the structure of the hemoglobin molecule, making it easier for the third oxygen molecule to bind. and so on. So it's not just statically binding, each binding actually changes the structure of the hemoglobin molecule, and the 4 subunits combine sequentially with oxygen. Each individual combination affects the affinity for oxygen of the remaining subunits. The overall hemoglobin affinity for oxygen is affected by these 4 things, so temperature, metabolically produced molecules such as H+ ions, which increase the acidity, carbon dioxide and diphosphoglycerate. We'll have a closer look at these later. So what is the relationship between the partial pressure of oxygen, so how much oxygen is present, and the hemoglobin-oxygen binding? So the concentration of dissolved oxygen in the blood is proportional to the solubility coefficient and the partial pressure of oxygen as well. So 2 things that affect the amount of oxygen dissolved in the blood. Imagine that there's 2 solutions of oxygen separated by a semi-permeable membrane in a sealed container, and we give some time for the oxygen to equilibrate with equal partial pressure values on both sides of the membrane. So if you have something of this size, then let's say the rate of reaction is about 0.2 seconds. So the partial pressure on both sides of the membrane are around equal. I've tried to make it look around equal anyway. Now imagine that we add hemoglobin to the right side, and hemoglobin binds oxygen. So you can see that the hemoglobin is starting to bind oxygen. There's 3, it's almost saturated, there's 3 oxygen molecules per hemoglobin. And hemoglobin binds oxygen proportionally to the partial pressure. So 1 gram of hemoglobin can maximally bind 1.39 grams of oxygen. Now the partial pressure on the left side is greater than the partial pressure on the right side, because some of these molecules have been taken out of the system. This sign should be the other way around, my bad. But anyway, this side has a greater partial pressure than this side now, because only the 3 oxygen molecules contribute to the partial pressure. Now it's going to establish a new equilibrium where the partial pressures change. So the oxygen is going to diffuse from the side with the greater partial pressure to the side with the smaller partial pressure, and it's going to look something like this. The normal blood has about 15 grams of hemoglobin per 100 milliliters of blood. It's about 20.8 milliliters of oxygen per 100 milliliters of blood. So as we saw, this demonstrates that only the oxygen dissolved, is not the oxygen bound, contributes to the partial pressure. But hemoglobin binds oxygen proportionally to the blood partial pressure of oxygen. So when hemoglobin is present, there's more oxygen total, so the concentration of oxygen is greater at a given partial pressure. Now this has implications for the oxygen hemoglobin dissociation curve and its relationship to the total oxygen content. So you've probably seen this curve before. It's the sigmoidal curve, which describes the relationship between the partial pressure of oxygen in millimeters of mercury here and the percentage saturation of hemoglobin, so how saturated your blood is with oxygen. And the reason that this has a sigmoidal shape, so it kind of looks like an S, it goes slowly at first for a very short time, and then it rapidly increases the saturation as partial pressure increases, and then it slowly slows off there. So the sigmoidal relationship is as a result of the cooperative binding of the 4 oxygen molecules to the single hemoglobin moiety. So if we have a low partial pressure, then only 1 binds to each hemoglobin, and that changes the structure of the hemoglobin, so that makes it easier for the second one to bind. The second one does the same to a lesser degree, and then the third one just stops doing that, and the hemoglobin is basically saturated. That's why there's a sigmoidal shape. Now we can see that at lower partial pressures of oxygen, for example in the tissues, in the systemic circulation, the partial pressure at metabolizing tissues is lower. So what we want the hemoglobin to do here is to give up the oxygen, so we can get the oxygen to our tissues which need it for respiration. And that's exactly what it does. So the percentage of hemoglobin saturation is lower when the partial pressure is lower. It's markedly lower below 60 millimeters of mercury, and that allows us to give up the oxygen from the hemoglobin and give it to the tissues. So the P50, which is when the hemoglobin is 50% saturated, is about 27 millimeters of mercury. Now at the other end, in the lungs, in the alveoli, there's an abundance of oxygen, so there's a very high partial pressure of oxygen, and we can see here that the hemoglobin is very saturated up here, and we want it to be saturated because we want the hemoglobin to be able to bind the oxygen when there's a lot of it and take it to carry it around the blood. We want the hemoglobin to collect the oxygen from the alveoli. Now let's have a look at some typical numerical figures. So we've said that 60 is kind of the breaking point, so the hemoglobin saturation decreases greatly below 60, and past 60, the haemoglobin is largely saturated. At 100 millimeters of mercury, which is the normal alveolar partial pressure of oxygen, the haemoglobin saturation is around, or the oxygen saturation of haemoglobin is around 97.5%, and if it falls below that, then there's a problem, so we're not getting enough oxygen. And this is one of the things that they monitor in hospitals. A loading plateau, so this is past the 60 mark, and it says that the quantity blood of oxygen is not affected much by the partial pressure until the partial pressure is below 60. So if you're below 60 in your alveoli, the partial pressure of oxygen, then you're in trouble. Now we have a look at the dissolved and the total oxygen. The amount of total oxygen is going to be slightly higher than the amount of oxygen bound to haemoglobin because of this small amount of dissolved oxygen. We can see that there's the same amount here, so the total oxygen content is made up of the dissolved oxygen content plus the oxygen content bound to haemoglobin. Before the loading plateau, fluctuations in barometric pressure have very little effect on the quantity of oxygen carried by the blood. Yeah, we know that. And the quantity of oxygen in the arterial blood remains the same over large variations in ventilation rate. Changes in ventilation regulate the arterial partial pressure of carbon dioxide without really affecting the oxygen supply to the tissue, so that's another benefit of this adaptation. So is the haemoglobin saturation curve constant? No, it can shift under certain conditions, so we'll have a look at those now. Firstly, a left shift, and this is what it looks like in fetal haemoglobin. The fetus gets oxygenated blood from the placenta only, not the lungs. And in the placenta, the partial pressure of oxygen is pretty low. It's only 30 millimeters of mercury, as opposed to in the lungs where it's about 100. If the normal adult blood is about 55% saturated, then fetal haemoglobin will be about 75% saturated. And this means that it has a decreased P50, and it has a high affinity for oxygen. So it's left shifted. Also, this can be the case for stored blood in blood banks. People can donate their blood to blood banks, which is used for emergency transfusions, and the problem with this is that sometimes if it's stored for a long time, then the amount of diphosphoglycerate, which decreases the affinity for oxygen in the blood, can decrease, so that impairs oxygen loading, and there's a problem if lots of this blood is transfused because it will bind the oxygen too tightly and it will be difficult to get blood to the tissues. Now this is the normal curve, and then in green is a right shift, and depending on what the right shift is caused by, it can be called the Bohr effect. So right shift is in exercising muscle, and oxygen unloading is increased because the exercising muscle has all of these properties. So it's warm, has increased temperature, it's acidic, the pH is decreased, it's hypercarbic, so the partial pressure of carbon dioxide in the exercising muscle is decreased because of the waste gas production increases from respiration, and it produces a molecule called disphosphoglycerate, or 2,3-DPG, in its red blood cells. And when we're talking about decrease in pH or increase in partial pressure of carbon dioxide causing a right shift, we're talking about the Bohr effect. So 2,3-DPG is an organic phosphate containing molecule which is higher in the red blood cells than other tissues, and it's higher especially in exercising muscle. The red blood cell shunts 1,3-DPG to 2,3-DPG, so it changes the structure. It changes the position of one phosphate to the 2 position, and this is happening via an enzyme called DPG dismutase. DPG has increased affinity for adult hemoglobin A than oxygen because it displaces oxygen at a given partial pressure of oxygen. So it will kick the oxygen out of the hemoglobin and it will bind to hemoglobin instead. Fetal hemoglobin is less sensitive to 2,3-DPG, thus there's a left shift. So these 4 key factors which cause a right shift in the hemoglobin curve, and that decreases its affinity and increases its P50. Now oxygen content, we've said from this graph that although most of the oxygen is bound to hemoglobin, there's still some that's dissolved. So how do we calculate the total blood oxygen concentration? The arterial partial pressure of oxygen is only related to the amount of oxygen dissolved in the blood, not including the amount bound to hemoglobin. The oxygen content keeps us alive, which is not just the partial pressure of oxygen or hemoglobin saturation, so we do need to consider the total oxygen content. How do we calculate this? So the total blood oxygen concentration equals 1.39 times concentration of haemoglobin times percentage saturation of haemoglobin plus 0.003 times partial pressure of oxygen. So the blood oxygen content is in milliliters of oxygen per 100 milliliters of blood. 1.39, where does this come from? So it's the fact that 1.39 milliliters of oxygen per gram of haemoglobin associates. So this is the max oxygen amount bound by 1 gram of pure haemoglobin. And haemoglobin in grams per 100 gram times the percentage saturation plus this 0.003 comes from the fact that 0.003 milliliters of oxygen binds per 100 milliliters of blood per millimeter of mercury. And now we're timesing the partial pressure of oxygen in millimeters of mercury, so that gives us the total blood oxygen content. And we can see from this graph here that there's varying levels of this. So if someone has very low concentration of haemoglobin, so 10 grams of haemoglobin per 100 milliliters of blood, then their concentration of oxygen will be pretty low and they'll be anemic, which means they're not getting enough oxygen and possibly they're not having enough iron as well in their blood. A normal value is around 15 grams of haemoglobin per 100 milliliters of blood, which is around 10 to 20 milliliters of oxygen per 100 milliliters of blood. And then a polycythemic person, so someone that's creating a lot of blood vessels, maybe they live at very high altitude, they'll have about 20 grams of haemoglobin per 100 milliliters of blood, so they have between 20 and 30 milliliters of oxygen per 100 milliliters, which is a bit much at ground level anyway. And this shows the various oxygen saturation percentages of these people. Blood gas disorders are respiratory states characterized by abnormal blood gas levels. So you can have too high or too low oxygen or carbon dioxide. Now there's 4 main variations of this. So we have hypoxia, hyperoxia, hypercapnia, and hypocapnia. So hypoxia, low levels of oxygen in the blood. Hyperoxia, too high levels of oxygen. Hypercapnia, too high levels of carbon dioxide. And hypocapnia, too low levels of carbon dioxide. Now hypoxia is insufficient oxygen at the cellular level, and there's 4 categories that can be split into. So firstly, hypoxic hypoxia, pretty self-explanatory, low arterial blood partial pressure of oxygen and inadequate hemoglobin saturation. Anemic hypoxia is the reduced oxygen carrying capacity of the blood, so someone, for example, might not be getting enough iron in their diet, so their blood can't carry oxygen as effectively. Circulatory hypoxia is too little oxygenated blood delivered to tissue, so there might not be a problem in the blood carrying the oxygen, but there might be a problem with delivering the blood. And histotoxic hypoxia is when the normal tissue oxygen delivery happens, but the cells are unable to use oxygen. So there's not a lack of oxygen, but your cells are just unable to take it up and use it for respiration, for example, in cyanide poisoning, which affects the electron transport chain. Now, hyperoxia is when the arterial partial pressure of oxygen is above normal, so it's above around 100 millimeters of mercury. Hypercapnia is when excess carbon dioxide in the arterial blood happens because of hypoventilation, so not breathing deeply or enough, and get too much carbon dioxide building up in the blood. Hypocapnia is when your blood partial pressure carbon dioxide levels fall below normal from hyperventilation, so breathing too much, you're not having enough carbon dioxide in the blood. And we can remember the alveolar ventilation equation, which tells us that the alveolar ventilation is inversely proportional to the partial pressure of alveolar carbon dioxide. So to decrease the carbon dioxide levels, we need to breathe more deeply and we need to breathe faster.